Hello and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we're going to be discussing the wound bed preparation model. So we've recently gone from time to timers, okay, in the wound bed preparation. So that is what we're going to talk about today, the changes, and go over timers. But first, if you could hit that subscribe button, it would be greatly appreciated as it truly does help my channel. So let's get started. So what is the wound bed preparation? I am going to do kind of a little bit of a review here. If you haven't seen my other video on time, or if you're not sure what wound bed preparation is. So wound bed preparation is a systematic approach for clinicians to identify and remove barriers to the healing process, okay? So we're optimizing the wound healing environment and focusing on all critical aspects of the patient, okay? These can include debridement, bacterial balance, exudate management, and the patient's overall health status. So originally we used the concept T.I.M.E.R.S, okay? So it stands for tissue, infection and inflammation, moisture balance, and edge of the wound. Now, in 2018, a panel of wound care experts came together and have now created an update to T.I.M.E.R.S, and now we're using T.I.M.E.R.S, okay? So the advances in wound care practices, technology, patient care has made this update. So now we're adding repair or tissue regeneration and social factors, because often social factors are really overlooked when we're looking at the patient's wound. And like I always like to say, we want to look at the patient as a whole and not just the hole in the patient, okay? So suggestions of biofilm prevention and management were also raised in this meeting. So now T.I.M.E.R.S does include that also, which you will see here later in the slides. So we're going to go through each step of T.I.M.E.R.S, okay? So the first one, the T, tissue management. So tissue management is focused on viable tissue, okay? Is the tissue viable, or is there presence of non-viable, necrotic, infected tissue that is slowing down or stopping the healing process? If this is the case, then debridement is recommended. So what is the goal of debridement? So we are removing necrotic tissue or debris. We're stimulating the wound. We're inspecting the underlying tissue, okay? Because we want a nice wound base, okay? We want it just moist, a pinky red color. That's perfect for healing, okay? So we're going to remove, exudate, and promote healing, okay? So what type of debridement methods are there? Now there's autolytic, enzymatic, biological, sharps, surgical, and mechanical debridement. If you would like to know more information about this, I'll have a link just up above here that goes over, there's a video of all the different debridement methods, and I can also put the link in the description. Next, we have inflammation and infection. So an infected wound will cause the patient discomfort, pain, and it also delays wound healing, okay? Now, there has been an emphasis placed on bacterial burden, okay? But oftentimes what is missed, a missed component, is host resistance, okay? So that should definitely be factored in when we're looking at infection. So this resistance is lowered by poor nutrition, poor tissue perfusion, smoking, substance use, comorbidities, and medication, okay? So those can affect infection, okay? So if we're unable to heal properly and actually combat those infections, host resistance is a big part of this. So we need to be looking at that. So treatment should actually start with improving host resistance by promoting healthy eating, encouraging to either stop smoking or reduce smoking at the very least. I know it can be very hard when talking with patients to get them to stop smoking, but if we can even reduce it by 50%, I am okay with that. Okay. We want to address any underlying medical conditions such as diabetes. Okay. We want to make sure that their sugars are in control so we optimize wound healing. Okay. Now, interventions for controlling inflammation and bioburden include debridement of tissue that is not any good. Okay. So, devitalized tissue, we need to be removing that. Cleansing with non-cytotoxic cleansers. Okay. So, saline, non-cytotoxic cleansers. The use of topical antimicrobials or antibacterials. Okay, this will help reduce the bioburden, and antibiotics if you're treating a systematic infection. Now, if you're unsure if you need to treat topically or systematically, I'm going to link a video here. We need to know our NERDs and stonies. If you do not know what NERDs and stonies are, please watch this video. I will also link it at the end. Super, super important to know what type of infection you are dealing with, and NERDs and stonies will give you just that. Next, we have moisture balance, okay? When it comes to wounds, we want a just moist wound, okay? Like our eyeball. That's how I like to explain it. We want it just moist, but we don't want it too oversaturated. So it's a very delicate balance when we're talking about wound moisture balance. If we have too much moisture, we can have maceration. Now, maceration is where it becomes white around the outside of the wound, where it's saturated. We've probably all had this at one point when we've been swimming and our fingertips go white. That is maceration. Now, when we have that around a wound, it will actually start degrading the wound. Okay, so the wound will get larger. We don't want this. That's why I say it's such a delicate balance, because we want a moist wound, but we don't want it too moist. Also, if it's too moist, this will also promote biofilm formation because we're giving it a potential nutrient source. Okay, so we want just moist as our eyeball. To ensure an even balance of moisture levels, we're going to use dressings that either donate while also absorb moisture. So it's leaving the wound not dry, just moist. The different types of dressings that we can use for this are transparent films, hydrocolloids, hydrogels, foams, alginates, and super absorbent polymers. Okay, those are all the different dressings that we can use. This promotes absorption. Okay, the transparent films, those don't have absorption capabilities, so it would be used for more drier wounds, but the rest, they will absorb while also leaving that wound just moist. Next, we're looking at the wound edges. Okay, this wound edges are so important while looking at a wound. This is going to determine whether a wound can actually heal. If there are things going on those wound edges, that doesn't optimize wound healing, it is going to get stuck in that phase. So the following observations can confirm whether the wound edges are advancing as normal. So if we have rolled edges, advancement of our edges, calluses, scales, dry skin, eczema, psoriasis, irritation, sensitivity, those will all determine whether the wound is going to close or not. Okay, advancement of the edges where it's starting to go towards the center, this is what we want to see. Now, interventions for non-advancing edges or for rolled callus edges is debridement. Okay, debridement of those rolled edges or callus edges. If we have that thick calluses, and I see this so much in diabetic foot ulcers, is where we get a callus right around the wound that needs to be debrided. It is non-viable tissue. It will not allow that wound to close if we have that callus there. Okay. With diabetic feet, we have to be super, super cautious though when we debride. Okay, so it's a very catch-22 with wounds because we can't be going down too deep on the callus of diabetic patients because we don't want to make anything worse. They are at huge risk of infection. So we just want to take that layer off, that top layer, and we might have to just keep up with this every week, but that's okay. It will help the wound close. We need infection management. We need to pack any tunnels or undermining in the wound, and then just peri-wound management in general. So regeneration and repair. Once we are finally at this step, these are the new steps, okay, in T.I.M.E.R. So once we're here, we want to address hard to heal wounds. So we want to encourage the closure of the wound by providing matrix to support cell infiltration, stimulation to cells, growth factors, delivering oxygen, using stem cells. So clinicians should establish whether the wound responds to standard of care. Okay, can we get the wound to heal with normal standard care? Okay, all patient risk factors should be identified. Critical factors should be addressed, including any underlying infections, disease, presence of biofilm. By this step, we should have all of these looked at, including patient-related factors. Now, once risk factors and standard of care have been addressed, hard to heal wounds, we can start looking at advanced therapies. So I did put the advanced therapies down here: nitric oxide, oxygen therapy, growth factors, placental-based grafts, cell-based grafts. There are so many different advanced therapies that we can go to, but they are more expensive. That's why we want to look at the standard of care first before ever moving on to advanced therapies. That's why wound care documentation is so very important. We want to be measuring once a week the wounds. We want to be recording exactly what we're using, what we're seeing. That way we can see progression and seeing if the standard of care is working. So finally, social factors. So this is the last thing that we're going to look at. And like I said earlier, we want to make sure that we're looking at the patient as a whole and not just that hole in the patient. This fixes so many problems because in wound care, we always have to look at what's caused this wound. Okay, what was the cause of the wound? Is it swelling? So venous leg ulcers, is there swelling? Is that return of blood flow not there? Do we need to put them in compressions? For that just for example, we're not going to heal a wound that's been caused by swelling and venous stasis, so the veins not bringing the blood back to the heart appropriately. How can we treat a wound that's caused by that if we're not treating the cause and getting them in compressions, right? So always look at the patient as a whole, not just the hole in the patient's. So we do need to be considering different factors. So psychological, intrinsic, physical factors are all part of wound healing. So mental health, we need to make sure that they're understanding the care that they're getting. Okay, why are we doing what we're doing? And then patients with dementia, they need to have support. They need support because they're not, sometimes it depends on how advanced stages they are, but they're not going to be able to provide that self-care. Then the use of medical jargon. On this channel, I'm not sure if you've noticed, but I really try to not use medical jargon. And if I use it, I try to explain it in a different way also. I do this because I don't want people to have to go look up every single word that I say. I want them to fully understand what I'm talking about. And sometimes we get where we're talking and people are just not understanding, but they're scared to say it, right? They want you to think that they're understanding you, but they don't. So that's why I really try to use just normal language while talking with my patients. Next, physical factors and comorbidities. So physical factors can really contribute to the effectiveness of wound healing. Is there a lack of mobility? Can they reach the location of their wound? Can they provide self-care to that healing wound? Or is it in a location where, oh, it's on my hand or on my wrist, and I only have one hand to provide this care? Is there someone that can help them? We have to think of every aspect from taking care of that wound. Extrinsic factors, so living conditions, self-isolation, are they close to a clinical office? Now I know where I'm located, we sometimes send patients to the clinic to be seen by nurses to perform their wound care. We sometimes have nurses come to their home. Now, it depends. Can they drive? Can they get to that clinic? If we're setting it up for them to go to that clinic, they better be able to get there. Or are they relying on family members to get them there? Family has to work too. We have to think about this. I know it's a cost. Um, we're always trying to save, especially living in Canada. There's such a toll of our medical system. We're trying to send as many people to the clinic as we can, but if we're just doing this without asking the questions, and I know this from experience because I have seen it where it has gotten so bad and it has gotten to a bone infection. And that's finally when doctors are asking questions. Well, why aren't you making it to the clinic every other day to have your wound care done? It's because they can't get there and they're only getting there once a week. And they've been throwing on a bandage or wrapping a sock around it because they don't have wound care supplies at home and they're not making it to the clinic or have no way to get there. Or if they're relying on a bus or a taxi, it could be money issues, right? So we need to put this all into place and look at all these factors because they do affect wound healing. So repeating this process. So wound bed preparation, it's not just a one and done type set of steps. Every time we're looking at a wound, we need to be assessing it. Okay. Are there changes? Do we need to go back and look at the wound bed preparation steps? What do we need to do? Because these steps are so vital in the wound healing process. And without going back to them, the wound will not heal because as we progress, things change within that wound. So we need to be reassessing. I personally like to reassess once a month. Okay. every 2 weeks, we're looking, we're seeing, do we need to look back at timers, or are we okay for that 1 month time? Me personally, when I'm looking and assessing a wound, I like to make it where we're doing something for 2 weeks. Okay. And then I know in my mind where we should be after 2 weeks, and then I give further steps. But if we're not there at that 2-week mark, then we need to be reassessing, seeing what we need to be doing. Okay. So I hope this video did give you a better understanding of timers and wound bed preparation, how we look at the patient as a whole and not just a hole in the patient. But that's all I have for this video, guys. I hope you did find it helpful in your practice, and I hope to see you in my next video. Bye for now.